Good afternoon. Welcome to the Center for Change webinar series. We're so happy you could join us today. My name is Tamara Bingham. I'm the Director of Business Development here at Center for Change. I'm here with Claire St. John, our presenter. We're so excited to have Claire present for us today. We have just a couple of housekeeping items that we need to do right off the bat, and then we'll turn it over to Claire. And you'll see those items on your screen. So first, a copy of the PowerPoint is in the handout section of the toolbar. You'll see your toolbar. If you click on that little arrow, it'll pop down and you'll see two options there, and the handout is one of those. And a copy of the post test is also there. So you could take a look at the post test if you'd like. I'll talk more about it in just a minute, but you're going to take the test online in order to receive continuing education credit. But you can take a look at the post test throughout Claire's presentation, so you can keep an eye on those test questions that are going to come up later. You're welcome to submit questions in the questions section of the toolbar. You just type those in. I'll monitor those throughout Claire's presentation, and then when she's finished with her presentation at the end, I'll pop back on and we'll try to get to some questions before we run out of too much time. So feel free to send those questions throughout, and I'll pay attention and keep an eye on them, and then we'll get to some at the end. When the webinar ends, there'll be an evaluation that will automatically pop up on your screen. If you'd be so kind as to take just a minute to fill out that evaluation, that would be really helpful for us. That's a continuing education requirement for us. It's completely anonymous, so feel free to be candid in your feedback. We then tabulate those results and send those to the CE providers as part of our agreement with them that we would send that data when it's over. And then about an hour after the webinar is finished, you'll get a separate email from GoToWebinar. It will look similar to the email you got when you registered. And in that email, it will have the link to take the online test. And again, you must take the test online in order to receive continuing education credit. Once you complete the test and pass it, then your continuing education certificate is automatically downloaded to your device. If you don't see it on your screen, check your downloads folder. It could be in there. Okay, with that said, we're ready to turn it over to Claire. I'm really excited to have Claire here with us. Dr. Nicole Hawkins, who's the CEO of Center for Change, has been at Center for Change for 28 years. She and I had the opportunity to see Claire present about a year or so ago, and we both turned to each other and said, oh, we got to have Claire present in our webinar series. She's amazing. Claire is the Director of Operations for Reasons Eating Disorder Center. She's a registered dietitian and also in private practice. Claire is a certified diabetes. Nope, that's wrong. Sorry, I'm getting my things mixed up. She's an certified eating disorder specialist. There we go. We treat diabetes at Center for Change, and my brain just shifted. I apologize, Claire. Claire's also a supervisor for that. She practices health at every size and intuitive eating, and we're just so happy to have you with us, Claire. So with that, I'm going to turn it over to you. So give me just a second, and we'll make you the presenter.
All right. Thank you, everybody.
You're up and running. I don't see it yet.
Hang on.
So when I do, then I'll hop on. There we go. Okay, I'm gonna turn off my mic and my camera, but if you need me, I'm right here. Just holler and I'll pop back on. Otherwise, I'll come back on at the end of the presentation and we'll take some questions at that point.
Okay, great. Thank you everyone for being here. I'm really excited to present on this topic. I am not sure how long I'll be able to see myself, so if I leave camera or something, or I don't know, have a funny face, just forgive me because I'm used to being able to see myself. As this is a presentation about language, I should take a minute to talk about my background, the words I use, and why. I have been a registered dietitian nutritionist working in the eating disorder treatment field for about 10 years. Before that, I was a newspaper reporter for about 7 years, so I have always been interested in the power of words and how easy it is to miscommunicate or be misunderstood. When I ask patients to repeat back to me what they heard me say, I'm often shocked at how much they read between the lines, made assumptions, or taken something I said in a very different direction than I intended. I want to acknowledge before we start this presentation that I have never lived in a larger body, which means all of my information about the difficulties, the discrimination, the assumptions, and the barriers of living in a larger body are all secondhand from friends, family, and clients, which I appreciate them very much for. It's only in the past year or so that I've become comfortable using the word fat in a neutral way, because it has for a long time had such negative connotations for a lot of people. When I work with patients and clients, I think it's important for them to self-identify, and I use the words they choose for themselves. Sometimes they will call themselves fat in a derogatory way, which can be an opportunity for me to reframe for them, introduce them to fat positivity or fat activism, talk to them about diversifying their social media feed with a variety of bodies and looking at things differently. In the course of this presentation, I will use the words obese and obesity when we discuss studies and medical recommendations that have come out recently, because that's the language that they use. But I have otherwise attempted to eliminate those words from my vocabulary. And I'll talk a little bit more about why as well. So what I would like to talk about today is how our beliefs, experiences, and understandings influence the words we choose when we're providing treatment at all levels of care, and how impactful our words are to our patients and clients. Specifically, I'm talking about our culture's widespread and deeply rooted fat phobia, and how a lot of things we were trained to do and say, or the ways we've learned to navigate patient fears about treatment and recovery, can reinforce that fat phobia, not only for our patients and clients living in larger bodies, but for everyone. So what eating disorders are we talking about? All of them. Our word choices impact recovery for people of every size, in every group, at every stage of recovery, whether they've been identified as needing to gain weight, and for those for whom weight gain is not the identified need or goal. We'll cover what nutritional restoration means, what it looks like, and how to talk about it to patients and clients at every level of care without instilling fat phobia or causing harm. We'll consider words and phrases that have problematic or confusing impacts on people working on nutritional restoration, and we'll also look briefly at some special considerations that should be taken into account when talking about weight and body image in eating disorder treatment. Body image is such a rich, interesting topic to explore because it's almost never about the actual body. Clients can describe how they look in the mirror and think, okay, looking pretty good today, and then check themselves an hour later and see all their flaws, feel like they've gained weight, wonder how they ever thought they looked good. So it's a shifting, subjective thing. It's never set in stone, and it has so much richer meaning than just the appearance of the body. It changes based on how you feel, who's around, what happened yesterday, what you ate, how full you are, and even how well you did at some task or challenge or another. Feeling negative about the body is often a shortcut for dealing with negative feelings from some other source. The body is a more convenient scapegoat or target for negative feelings than looking at the actual source of that negative feeling, especially if our clients or patients are perfectionists and they feel like they're failing in some way. That feeling will orient in and on the body. For those that have trauma, focusing on the flaws of the body may actually be a protective mechanism because they feel like they can do something about what they perceive as wrong with their body when the trauma can be too overwhelming to approach or even look at. And feeling negative about the body is often expressed as feeling fat. I feel fat today. Look at me, I'm so fat. And outside of eating disorder treatment, sometimes within it, the response to make that person feel better is, no, you don't look fat at all. What are you talking about? This response perpetuates fat phobia. And as we'll discuss, it's harmful to the recovery of everyone, whether they're thin, fat, or somewhere in between, regardless of their gender or identity. It's important to recognize and internalize that there's nothing wrong with being fat. This will alleviate any unnecessary negative feelings you have about your own body and may protect you from unintentionally saying negative things about the bodies of others, especially those in our care as patients and clients. If you have any concerns that being fat is bad for your health, we'll discuss that further in upcoming slides, and there's also a wealth of studies that refutes that. If you have any concerns that society is harder on people in larger bodies, that our physical world is not built for people in larger bodies, and that people generally feel free to make comments about and to people in larger bodies, you're right. and undermining your own negative feelings about fatness is one small step in undoing this harmful cultural stereotype. It's important also to remember that fat is really not a feeling. It is a macronutrient in food that keeps us alive. It's a necessary and functional tissue in our bodies. And more, it's a neutral descriptor that people are taking back from those who have used it harmfully. So to expand on this concept that the words we choose have an impact on everyone, I want to use this slide as a brief overview of eating disorder diagnoses for those who are newer to the field, and to emphasize how language around body image and weight loss or gain impacts everyone. And this also applies to your friends, families, coworkers, acquaintances, but I'll stick to elaborating on how it impacts those with diagnosed eating disorders. Anorexia nervosa has as its criteria a severe restriction of food intake and low body weight, accompanied by a desire to lose weight. Atypical anorexia nervosa is severe restriction of food and a desire to lose weight without the presence of low body weight. Binge eating disorder is consuming a larger amount of food in a set time than is typical several times per week. Bulimia nervosa is consuming food and compensating either through laxative abuse, vomiting, or exercise. Avoidant restrictive food intake disorder, or ARFID, typically orients around a concern with textures, difficulties eating, or a fear of vomiting or choking that result in low body weight or malnutrition, but do not have body image as a component. And other specified feeding and eating disorders, or OSFED, is a catch-all for any issues with food that impacts quality of life or the ability to function normally. Atypical anorexia, which you'll recall is a restriction of intake without low body weight present, is actually nested under the OSFED diagnosis. I mention this because I think it's interesting. I think it does make the disease seem less emergent, less important to address. All of these diagnoses are of course important, but I think it's interesting that they took that away from anorexia nervosa and nested under OSFED. You guys can still see me. It really impacts how people perceive their bodies, how they perceive their diagnosis, their need for nutrition and nutritional restoration, and their expectations for recovery. So for all of these diagnoses, a patient or client might meet with a psychiatrist, a medical doctor, a therapist, a registered dietitian, and at higher levels of care, nurses and non-licensed staff, talking a lot of the time about food and body image. For all of those diagnoses and all of the varying body sizes, cultural backgrounds, ages, genders, and identities that come along with them, we as clinicians have to be very aware of our own opinions or beliefs about food, eating, and bodies, and observe ourselves for any changes in our language as we respond to people with different presentations. Are we operating under the assumption that this body needs more food than that body? Are we serving people different foods or different portions? Are we ensuring that all clinicians and staff interacting with our patients are asking themselves the same questions and being mindful of the language they use for patients and for different patients? Okay, we're good. Nutritional restoration is dietitian-led, but because eating disorder treatment requires a team of clinicians and support people, everyone needs to be on the same page and understand what it is, what the purpose is, and who it applies to. Anyone who has been diagnosed with any eating disorder requires nutritional restoration, period. This might be an obvious statement to everyone here, but we might think the need is more urgent when faced with someone in a thin body and less important when faced with someone in a larger body, and our language may reflect our assumptions. This is critically important to keep at the top of mind at all times. People with atypical anorexia nervosa have, just like their very thin peers, been starving themselves, cutting out foods or food groups, over-exercising, and or losing weight rapidly. Atypical anorexia can be very dangerous because a person who isn't underweight may fly under the radar longer. And because of their weight, they may not consider themselves to have an eating disorder. They may think all of their behaviors are to the benefit of weight loss, and for that reason, they're fine. They may, in fact, have been encouraged by medical providers focused on weight loss to keep doing whatever they're doing without questioning further, right? So if they asked how weight loss was occurring, they might discover that the patient is engaging in some pretty risky behaviors around food and exercise. But it seems like the typical standard is just to be pleased that your patient is losing weight. So you just encourage them to keep doing it, however they're doing it. If behaviors include purging, of course, the risk to a patient of any size goes up, right? So in a lack of nutritional intake, with the addition of purging, you can have electrolyte imbalances, and heart attacks or strokes can occur in someone of any body size. But again, in people with larger body sizes, that will go missed more frequently. Ensuring adequate food and the ability to eat to fullness is the goal for all patients. We, of course, train our staff in eating disorder programs not to say stuff like, wow, that's a lot of food, I can never eat that. But similarly, the entire team needs to know and understand that making promises that the dietitian won't let you gain weight, or don't worry, this medication isn't one of the ones that make you gain weight as a side effect, these statements are detrimental to recovery and care. Often we're saying things like this to diminish anxiety and fear, which our patients have high levels of around weight gain, but they are damaging in the long run as they reinforce that weight gain is the worst thing that can happen to anyone. What if a patient is already in a larger body? Or what if the thin person in front of us is actually a much bigger person when they're in recovery? The goal of nutritional restoration isn't to restore the body to a normal BMI or an ideal body weight, both of which are terms that have historically been used in eating disorder treatment. It is to restore the body to the best level of functioning at whatever weight that might be for each individual person. So that means being responsive to a client's hunger and asking yourself as the clinician frequently if you're subtly pathologizing that hunger, or asking the person if they really need that much, or if you're in charge of their food, if you're in a treatment facility, are you serving them smaller portions than you're serving other people? Or different foods. Everyone deserves to feel full and nourished. To promise someone who is not low body weight that there's no need for them to gain weight reinforces restrictive behavior, reinforces the idea that they need less than others, and reinforces that to gain weight is something negative and fear-inducing. This is a huge barrier to recovery. I feel like I'm a slide ahead of myself. Hang on, guys. Let me just take a mo. I think I need to be here. Sorry, you might have to stare at this slide a little bit longer. That's on me. Okay, let's keep going. The body image challenges patients face during nutritional restoration also present a thorny language challenge for clinicians. As patients start to eat more consistently, their fear of weight gain and internalized fat phobia will likely spike, and they'll want to process it a lot. Oh. Yeah, we're good, sorry. Want to process it a lot. This is where I think a lot of us have a natural instinct to minimize how much weight a patient needs to gain and make vague promises that we won't let it get too far, or it's not our goal to make you overweight. These statements align with the eating disorder and not with the recovery, and they can stay with people long after treatment. If they do gain weight above what they expected or what you promised, they might consider it their fault and turn back to eating disorder behaviors. Hang on, guys. I am really sorry, but I think these slides are being crazy. Yeah, they are. We are like way off. Now we're at the end. Hang on, hang on. Don't worry. Don't worry, everybody. All right, so I am on slide 8. Okay, it does look like we were okay. Boop. Okay. This is slide 8. Okay, so nutritional rehabilitation is a big part of eating disorder recovery at any level of care, and so is exploration of body image. Body image concerns are often the initial trigger for an eating disorder, and based on treatment outcomes of research, can often linger throughout the process of recovery. So even as attitudes and behaviors around food and eating improve, body image issues are pretty intractable according to research. As we discussed before, the body is often the screen that our disappointments are projected onto, or the canvas on which we try to right our wrongs. The shifting nature of body image can really illuminate this, not just for our clients, but for ourselves. When a client talks about feeling fat to express negative feelings, identifying the source of that feeling can be enlightening. Are you feeling fat, or are you upset about something your boss said to you today? Are you feeling fat, or did you do worse on that chemistry test than you expected to? Are you feeling fat, or do you feel lousy about how you just talked to your kid? Are you feeling fat, or did something just remind you of your trauma? When we feel out of control, or like we're not aligning with our values, or like we did something wrong, it's a fairly natural response to turn to something it feels like we have ultimate control over, our bodies. After saying all of that, I want to reiterate that there's nothing wrong with being fat, but it's not a coincidence that a lot of people express negative feelings by saying, I feel fat. And honestly, there may be a time when you ask, are you feeling fat? And the answer is, no, I am feeling fat because I have been discriminated against because of my body, or something was terrible said to me. Something terrible was said to me recently. The US is not a kind place for fat people. Much of the world is not a kind place for fat people. Fat phobia is sometimes referred to as the last socially acceptable prejudice, and is primarily because of the medicalization of fatness. That is to say, fat phobia is cloaked in a concern for health. It was on full display earlier this year when the American Academy of Pediatrics determined that obesity is a disease state and not the fault of the fat person. As such, they recommended an aggressive approach to adolescent fatness, including nutritional and therapeutic interventions for children as young as 2, weight loss medications like Ozempic, prescribed for children as young as 12, and bariatric surgery for those as young as 13. The message of these recommendations, it seemed to me, was thinness at any cost. It didn't matter how you got there, the goal was to get there. No matter that we understand these recommendations deepen fat phobia while doing nothing to address systemic causes of weight gain, and that we're putting children on medications that they will have to be on for the rest of their lives. And there's not much research on someone being on one of those medications for 60, 70 years. The AAP's recommendations further medicalized fatness, calling it a disease that needs to be treated. The interventions recommended have known and unknown risks and serious complications, while different body sizes are normal human variation. Being fat is not a disease. Some diseases are associated with fatness, type 2 diabetes, heart disease. These are diseases and they deserve to be treated, but they occur in people in smaller bodies too. You can see how fat phobia can make our healthcare system treacherous for everyone. There are reports, studies, anecdotes about fat people not seeking out care because they are worried about being shamed for their bodies, and underlying diseases get missed and they are not treated. There are so many reports of people going to the doctor and making a specific complaint, but being told that they should lose weight, and that specific complaint is not addressed, and people die or remain sick. And it affects people in smaller bodies too, because if that is a disease associated with fatness, then the person in the smaller body might not consider it a possibility for themselves, and similarly the doctor that they're seeing might not catch it if it's not on their radar. So this is the basic message of health at every size, right? And hopefully most of you have heard of health at every size. If not, definitely seek it out. It's really important. The principles are there in that slide. Basic message is just that everyone should be assessed on actual health indicators like labs, patient reports, and daily behaviors rather than on the size of their bodies. So many of our patients have reported that they eat well, exercise regularly, and feel great, but they were told to lose weight. So maybe they go on a diet, they restrict food, they exercise harder, they might try eliminating a whole food group. They might become obsessive about food. They might develop an eating disorder. Weight loss may occur, but the body really fights to be at the size at which it functions best. So regain of the weight is typical. Weight cycling can result in which a person diets, gains back the weight, diets, gains back the weight. When a person weight cycles, they slowly change their body composition. So when we lose weight, we tend to lose it in fat and muscle tissue. And then when we gain it back, it tends to be in fat. So over time, the body composition changes, teaching the body that there are deprivation and feast states also aggravates weight cycling. And many people end up at a higher weight than when they started, making them vulnerable to disappointment from their healthcare providers and making themselves vulnerable to more recommendations to lose weight as well. In asking for weight inclusivity instead of the medicalization of fatness, health enhancement instead of weight loss, eating for well-being instead of dieting, respectful care instead of dismissiveness based on body size, and life-enhancing movement rather than exercise for weight loss, I really don't think that Hayes is asking for very much. But fat phobia is so entrenched that this seemingly simple request for basic human decency is more like a battle cry most of the time and remains controversial, as evidenced by the AAP's recommendations and the skyrocketing prescription rates for Ozempic-like drugs. Rather than accept the idea that fat people can be healthy, we have this concept called the obesity paradox. The finding in some studies of a lower mortality rate for overweight or obese people. So it seems researchers can't accept their own research a lot of the times that shows that people in larger bodies can be healthy. In 2005, a quantitative analysis of several studies involving more than 600,000 people found that the vast majority of those in the overweight and obese categories, according to current definitions, do not face any meaningful increased risk for early death. A 2021 study found that 40% of obese people in two large, well-regarded ongoing studies were metabolically healthy. But even faced with those statistics, researchers couldn't do it. They couldn't overcome their fat phobia. They wrote in the study, "It is debated whether any form of obesity can ever be considered healthy, or whether the metabolically healthy obesity phenotype is merely a stage in transition to developing metabolically unhealthy obesity over time." Which is to say, basically, they're not sick now, but they might become sick at some point soon, which I just feel like is true of anyone, anytime, anywhere. So it didn't need to be said, and it just doubled down on our assumptions about fat people, even when faced with the evidence, which I just find mind-blowing. I think it's a real sign of how entrenched fat phobia is. Working in the eating disorder world, I feel surrounded by fat positivity all the time. I talk about this stuff all the time. I feel like things are moving forward, but then I see something like that where I see the AAP's recommendations, and it's really disheartening for this basic human rights movement that these things are still happening, that fatness is still medicalized like this. So it's good to be aware of, right? Like in our small way, with the people that we work with, we can make a difference with this. We're really good at validating patients for their bravery in seeking help, noting the courage it takes to enter any kind of treatment. Patients and clients come to us in times of crisis, often desperate for a way out of their behaviors or mindset. So every word we utter can have an outsized impact. And a lot of times our own fat phobia can slip through. Because many of us treat adolescents whose bodies are growing and changing and kind of alien to them anyway, our words may have lifelong impacts. So we have to be very careful with our words, and we have to check frequently for what was received and what was understood by everyone we're talking to. So here's a list of words and phrases to consider, some of which we already sort of touched on. I think it's important to recognize the first line. I think we use these words all the time. I think most eating disorder treatment professionals still do. It's in our charting, it's in our documentation. Insurance requires it, but they carry moral value, right? If you start with normal weight right there, what is normal weight? What makes it normal? Why do some people get to be in this normal category? And then you have overweight, which all of these are based on BMI, right? So they're categories, they're based on weight and height, and you can go to bed one day normal weight, and the next day you've gained a pound and you are now overweight and subject to all of the disease states that are associated with being overweight. So each of these categories are very close together. You don't change overnight, but your categorization may change overnight. And we do make treatment decisions based on these, I think because of the medicalization of fatness and the role insurance plays as well. So while we may still have to interact with these words, I think it's really important to consider what they convey to ourselves and to our patients and clients, and really try to eliminate them from our language as much as possible. Body positivity, body neutrality, body liberation. These are all lovely concepts, but they can be very difficult for different people. It can be an onerous challenge. These words have also been co-opted by the wellness industry, which is not 100% negative. A lot of people feel like wellness is a softer culture than diet culture, but if you really dive into it, at its heart, all of its goals are around weight loss. So body positivity can be a challenging concept for a lot of our patients. We'll talk a little bit more about that also. Fat phobia impacts all of our patients of all body sizes. Telling people that they don't have to worry about being pushed into the overweight range during eating disorder treatment, along with the word overweight itself, like we talked about, implies that that would be bad, reinforcing that being in a larger body is catastrophic, reinforcing cultural fat phobia. What if our patient's set point weight is above what we've calculated or above what BMI considers normal? Reinforcing the idea that our patients should be at a certain weight that we've predetermined for their bodies based on a 200-year-old data set on Dutch men, which is what BMI is based on, limits each person's ability to listen to their body and explore with an open mind where it functions best and to truly recover from an eating disorder. It also limits recovery for those in larger bodies. I got to attend a presentation a couple months ago here in California by Shira Rosenbluth and Sharon Maxwell. Both of them now work professionally in eating disorder treatment. They identify as fat, and they both went through eating disorder treatment and recovery when they were younger. Shira Rosenbluth has written, I want to talk about what it's like to claw yourself out from the depths of hell of an eating disorder relapse and become fat again, only to be told by family and medical providers that it seems like you've now gone back to the other extreme. I want to talk about how it can still feel unbearably torturous to eat, even though you've done months and months of recovery and you're back in your fat body, and then have people ask, are you sure you need to eat that much? I want to talk about what it's like to experience self-doubt with every single bite you consume in a world that tells you that you're obviously doing something wrong if you're fat. I truly don't have the words to articulate the hell of living with an eating disorder and then have people tell you you've gone too far with your weight gain when every pound you gained in recovery was an agonizing battle in the first place. Dr. Lauren Mulheim, another eating disorder specialist out here in California, put it this way: when the only image we have of recovery is of a slim body, people who recover into bigger bodies may struggle with feeling like they are doing recovery wrong. They may even be told by other professionals that they're doing it wrong. Indeed, many professionals have reassured eating disorder patients that they would not let them get fat. This really extends the horizon of treatment for people in different sizes and shapes. If they feel like their body is still wrong when it is at its best functioning weight, they're going to continue to struggle against it, struggle with it, fight with it, engage in those eating disorder behaviors, and need more treatment. And I do think we have the ability to be complicit with that, or to recognize that and make sure we're not perpetuating that cycle. I think I did it again, guys. Hang on. What slide is this? Well, okay. I think this is a really important slide. Let me make sure I didn't skip any. We were just here. I'm going to copy the body image. Okay, all right, we're good. We're good. So this is a really important slide. I think this is how we start to do the work for ourselves. And maybe everybody here is really great at this. And if so, that's wonderful news. I'm happy to hear it. I know that I've had to do a lot of work with this, and it's been really surprising to me just to sort of understand my own assumptions and my own feelings about things. So asking yourself, do you fully accept HAES? If you need to learn more about health at every size, I'll give you a minute and you can do that on your own. But explore it, really read deeply into it, really see how you feel about it. Do you accept it, or do you still have concerns? And if you do have concerns, talk about them. Get consultation with somebody who specializes in this. Argue with them. Fight about it. Like it's really good to really explore it deeply, get your questions answered, and ensure that you are able to treat patients from a HAES-informed perspective. I think that's critically important. What are our thoughts about fat people? Again, like if you have a negative thought about your own body or the body of someone else that you see, if it pops up automatically and you're embarrassed and ashamed about it and you just stuff it back down, take a minute with it, look at it, ask where these assumptions come from. Do you still believe them, and why? And is that something else you need to really chew over with somebody and get to the bottom of? I do recommend this be in a professional consultation situation and not necessarily with friends who have lived experience, because that's really not their job. Be vigilant to not make any vague reassurances to patients and clients about their weight. While it's difficult for people with eating disorders to hear, we're not magic wizards who know exactly what their bodies will do when they're nourishing themselves and taking care of themselves. That's really for their bodies to decide. We're there to respond to what their bodies are telling us and hopefully do a good job of showing them the path to recovery. Ultimately, what they do with that information is up to each individual, but it's our job to remove roadblocks, not reinforce them. So these steps, for lack of a better word, they can be a good start to your process. How do we avoid using stigmatizing language and perpetuating harm? How do we make our treatment centers, outpatient practices, coaching businesses, and let's expand it, our homes, our schools, our friend groups, our family get-togethers, safe and welcoming for all people? It really does have to start with a serious and honest self-assessment. Because fat phobia is so entrenched and in some quarters righteously practiced and defended, it's not a stretch to think that everyone of every body size likely has some fat phobia. So how do we promote positive body image with language. We just learned how to sort of analyze our own language and our own beliefs and assessments. But how do we start to do something that creates change? Promoting positive body image with language is as important as identifying and eliminating fat-phobic words or phrases. So much of our social value is wrapped up in how we appear, and social media, film, and television mostly reinforces thin, white, heteronormative standards for women and muscular, white, heteronormative standards for men. We see actresses that are thin making more money. We see actors that are muscular making more money. I mean, it's very blatant, right? It's very much part of our commerce that people with thinner bodies are remunerated for it. The Economist did a study recently about bodies and what people are paid, and it was really enlightening. If I had read it before I got on this webinar, I could tell you more details, but I absolutely recommend that you look it up. So using patient-preferred words and language is a way to create safety and trust in any treatment center or setting, while gently questioning any negative or medicalized words for bodies like normal weight, overweight, obese. Again, not jumping down the throat of patients, of course, but just gently questioning like what that word means to them, why they use it for themselves, if they feel like it's the best descriptor for them, or if it has been put on them by someone else or somebody else's assumptions. I think it's important to learn to navigate when people are applying false barriers to their bodies, things like feeling like they need to wait to start dating, or wait to buy clothes that fit them, or wait to eat the foods that they like until they are in a thinner body. And then recognizing barriers that truly do exist for people. Uncomfortable airline seats that aren't big enough, rickety chairs with arms and low weight capacity, tiny bathroom stalls. It's not okay to be fat positive without recognizing how difficult it is to be in this world as a larger person. And if you work in a treatment center, lean into that environment and try to expand it out to the world around you. I don't know how many of you have experienced this, but creating an environment where we avoid talking about weight, exercise, and dieting, and focusing discussion around people's hopes, dreams, personalities, what they're interested in, memories, accomplishments, it's such a relief from our diet and wellness focused culture. It always felt like a bubble to me, but it felt like something I could expand. As I came to appreciate it more, I found I could kind of carry it with me and influence those around me. There was one experience I had early in my career that I thought was really impactful. I was on the train and there were two men sitting next to each other, and one was telling the other in great detail and description everything he had eaten that day. And I realized that my pre-eating disorder professional self would have thought nothing of it. It's not untypical. You see people doing this, talking about food in depth a lot. But with some eating disorder experience and exposure to an eating disorder treatment center that would redirect that, I saw it for what it was. The man was likely on a diet and he was likely really hungry. And so his brain was thinking about food and he was telling his friend all about it. But rather seeing that as problematic, I think it's just typical, right? We talk about our diets and our foods all the time. So really kind of seeing how we talk to our eating disorder patients, how we eliminate that from our speech, and carrying that with us to our other environments. It really makes a difference. We've gone over this during the course of this webinar, but it comes up with a lot of clients, this word fat as a negative. As a clinician, as you do the work or continue the work of examining any fat phobia you might hold on to, you can start using the word yourself. not to people necessarily, but just testing it out for yourself, seeing how you feel about it, and trying to incorporate it into your speech. I think it's helpful. I still have patients who refer to themselves as fat in a derogatory way, and I don't respond to it in a derogatory way. And it's an interesting course, like over the course of treatment, we both keep using the word the way that we think it should be used, but I can see it having an impact on her, and she's starting to use the word in a less derogatory way. So using the same word, but you can tell there's less energy behind it, which I thought was a really interesting experience. This will allow you to strengthen your ability to have similar conversations with your clients and hopefully begin addressing their fat phobia. As we discussed, relying on the phrase, "I feel fat," to describe some emotion or feeling really obscures whatever is actually going on a lot of the time, delaying the ability to address that thing or deal with that thing. So it's really a double-edged sword. You're both getting to the heart of the issue and you're working on entrenched fat phobia in people as you really kind of like lean into this word fat, right? I think it's something that we all shy away from. When somebody brings it up, we like try to bat it down immediately, like no. But really like embracing this word can be an interesting experience if you haven't done that already. So I just wanted to do some bullet points, kind of encapsulating everything we have already addressed. So addressing fat phobia, just to be clear, is for all cohorts, all body types. That's what it says for sure. Hang on, let me move this thing. That's not all milieus, right? That's important, I think. So that is to emphasize that you don't want to have a milieu of thin people and think to yourself, oh good, we don't have to talk about fatness now because nobody is fat. It's really for every single milieu, every cohort, every patient to both address their fat phobia and to smooth their way to treatment, to recovery, because fat phobia is a barrier for everybody. Reminder that eating to satisfaction or fullness is for all bodies, and to have some awareness about how you think about that and how you talk about that. Everybody requires nutrition, regardless of how much movement it's engaged in or what size it is. To emphasize this for my patients, a lot of times I will use the example of a person in a coma, right? They're in a hospital, they're in a coma, they're moving literally not one single muscle for 24 hours a day. But the doctor's response is not to say, he's good, he doesn't need any food, he's not doing anything. There's a feeding tube placed and daily nutrition monitored and given. We all need nutrition every single day, no matter how much movement we engage in. And then just a reminder, I know everybody knows this, but it's like, it seems like an important thing to reinforce, right? Weight does not equal value. So really trying to be aware of when your patients kind of talk about it as if it does. Again, recognize that there are indicators in our culture and our society that weight does equal value, but we have to fight against it and we have to be that change. Sorry, I just got all sad. Hang on one second. I'm pretty sure I wrote down something really impactful. I guess not. So it's important though. Weight does not equal value. Slide. Okay, so this and the next slide are just some considerations for treating body image in eating disorders, in eating disorder treatment. Both of these slides deserve an entire webinar to themselves. I want to emphasize that, but I just want to bring these up as something to be mindful of and maybe seek out more training on. Many of our patients have trauma, so keeping an awareness that a particular body shape or size may have offered protection at some point. that eating disorder behaviors may have been the only coping skill available in a difficult time or situation, and understanding the role food or eating may have played in a particular trauma and using the right modality to address it. So a lot of the things that we've already discussed can be brought to patients with trauma, but it needs to be done in a way with a lot of awareness and, in my opinion, a lot of respect for how they've coped. So a lot of times I talk about respecting the eating disorder, respecting the behaviors they've engaged in to get through whatever awful thing they got through. So almost mourning that we have to put those aside because they've become maladaptive. But I think that works really well for people because the eating disorder has been a shield at some point in their life, and it's hard to set aside. So being mindful of that and respectful of that, I think, is a really good way through. Treating eating disorders in trans, non-binary, and gender dysphoric patients also requires special consideration. Body positivity, body acceptance, and even body liberation might not be the right language for someone whose body doesn't reflect who they are. What I focus on in my practice is considering the body the place where you live, where your soul currently resides, and taking care of it for that reason. So while it's understandable and okay to want your body to change, starving the body, wearing uncomfortable clothes, punishing the body, it's just not necessary. It can be flawed and still be cared for. As clinicians, it's important to know if your patients are on gender-affirming medications and what the effects of those are. There's some body composition changes that might occur, and it's helpful to be aware of those and to give the patient support and feedback like that what they're experiencing is to be expected. There's also some mechanisms, biomechanical things with gender-affirming medications, such as that they're less effective in the absence of body fat, right? So just being aware of those things so that you can best guide your patient as they go through any transition that they may be going through. This too, I think, is a good place to talk about getting supervision, seeking out consultation, and learning as much as you can about different populations of people who will have eating disorders and need treatment for it. Referring out to a clinician that has more understanding or lived experience similar to a client's is such a good practice. But because the eating disorder profession does still skew mostly white, mostly female, mostly thin, and mostly heteronormative, it's really critical that we, all of us, all clinicians even, strive for more empathy, more understanding, more listening, more education about people's experiences in a variety of bodies. For all clinicians of any specialty, eating disorders will forever be walking into our offices. But are we receptive and aware of the different appearances and shapes they will come in? And do we have the ability to shift our language, our assumptions, and our beliefs to create the most supportive, therapeutic, and healing environments that we can? So just to recap a little bit, making body image a priority in eating disorder treatment, I feel like that's pretty obvious to everybody, but I do think it's a difficult topic. And so we may tend to avoid it for a long time, or, you know, bodies are very personal and individual and private. So patients may not want to speak up about it, but it's incumbent on us to try to explore that with them so they don't leave with the same kind of assumptions that they may have come in with. So continued learning and exploration for confidence in body image treatment. There's such great trainings out there. And like I said, I just like conversations with patients, candid conversations with patients are so instructive, and you learn so much. You really are an ally, you're just with them, right? You're with them as they're going through this process and trying to be a sounding board and support. Receiving feedback from patients and clients, you know, checking in, asking if the words you're using are correct for them or feel right for them or what it means to them, and using those words. And a real focus on body autonomy, I find that really important. Eating disorder treatment takes away so much body autonomy. For a time, they have to be told how to eat. They have to be told what foods to eat in a lot of instances, and it really takes away autonomy. So the way that I address that is I just try to keep it at the forefront. I try to validate that experience, recognize it, talk about why we do it that way, but also acknowledge how it takes away body autonomy and how I plan to give it back to them. And then understanding the shifting and impermanent nature of body image is important too, right? It changes up to minute. People feel differently about themselves, and trying to help people navigate why it may have changed. It might not be about their body, right? It might be about some comment somebody said that they immediately internalized and then sort of forgot about, but they still have this negative feeling that they're projecting onto their body. So I think that can be really helpful in navigating body image concerns and disturbances in eating disorder treatment. And that is my presentation. Thank you all for being here.
Thank you, Claire. We have so many good questions that we won't be able to get to all of them. And so we'll get to a few. I'll try and combine some that are similar. But if you all have a burning question that we don't get to before we have to end the webinar, you're more than welcome to email them to cfcwebinar@gmail.com, the email address that you all have for registration, etc. You can send it to me and I'll pass it along to Claire and see what we can do from there. Before we get to questions, let me remind you about two things. Number one, when I end the webinar or when you log off, either one, you'll have an evaluation pop up on your screen. If you would take just a quick minute to complete the evaluation, that would be really helpful for us. That's a continuing education requirement for Center for Change. It's completely anonymous, so please feel free to be candid in your feedback, and then we tabulate those results, send those results to the CE providers. And then lastly, everybody wants to know how to take the test. Just a reminder that once the webinar ends, about an hour after that, you'll receive a separate email from GoToWebinar with a link to take the online test. You must take it online in order to receive continuing education credit. Once you pass the test online, then your CE certificate will automatically be downloaded to your computer. If you don't see it on your screen, check your downloads folder. All right, Claire, here we go. I have to put on my glasses because this is really little, so bear with me. Okay, the first question, this is from Amy. Amy said, I often hear clients and friends talk about binging, and binging in quotes, and I sometimes worry how unspecific that term is. Is there a specific way you find helpful to look at it, or should we as clinicians accept that the client sees whatever their behavior is as binging?
I love that question. I have real issue with
I told you they're good questions.
I have issue with the DSM's definition because it is so vague. It doesn't help us navigate it. So I always kind of find a hallmark of binging a feeling out of control around food. So that's less about how much is eaten, right? That can be very subjective. That could be very little food, or it could be an enormous amount of food. But I think the problem is that feeling of out of control and where that arises from. Typically it's hunger. I mean, that's definitely the first bus stop I go to anyway, is assessing if hunger is present, right? If there's been consistent eating before the binge or not. So yeah, that's the quick hallmark that I use to kind of define a binge for myself in my work.
Great, thank you. Okay, this next question is from Anid. I'm not sure I'm saying that right, so I apologize, Anid, if I'm just butchered that. I'm so sorry. But it's similar to lots of questions, and basic, and I'll read their question in just a second, but basically the questions across the board are, yeah, how do you manage it when there may be physical symptoms that are happening due to, in this case, the word is obesity. So here's what I'm saying. I think I'm wondering how clients can advocate for other treatment options outside of just weight loss when it comes to conditions that is normally paired with obesity. Does that make sense?
Yeah, it does. I mean, I think people in larger bodies really, they hear a lot, right? That they can come in with a broken finger and the doctor will say, you should lose some weight, when that is not what they came in for, right? And it has nothing to do with their weight. So, but if they're having physical issues or they're in a disease state, that disease state should be addressed. So health at every size doesn't mean that everybody is healthy at every single size. It just means that health can exist in bodies of every size. So kind of like I was saying, like if somebody has diabetes and they're in a larger body, then you treat the diabetes just like you would in any body. That's kind of the decision, I think, just not pathologizing the fatness first, if that makes sense.
Right.
Like assessing the health of the person in front of you.
Thank you. Okay, Scott asks a question, and we had lots of these, which really warmed my heart. Scott said, how do I accelerate my personal growth away from my trained fat phobia / body prejudice? Do you have recommended books, articles, other resources? So lots of folks wrote in and said, how do I get better? How do I get more information? How do I improve? Which I loved.
This is my failure for sure, because I have tons of resources and I should have made a slide. So I really apologize.
No worries.
Come right to the top of mind is learning more about HAES, of course. The Body is Not an Apology by Sonia Renee Taylor. Fear of the Black Body, I think it's called, by Sabrina Strings. That's amazing. It really investigates the racism inherent in fat phobia and the historical sort of roots of it. And then just something simple like I said, kind of diversifying your feed, like exposing yourself to different bodies. Our media is really the same body over and over again, and it really sort of promulgates this idea that this is a normal body, right? So exposing yourself to more bodies, people in fat bodies who are happy and who are doing things, it can really be instructive. And it's kind of shocking how important it is, right? It's like, oh my gosh, everybody can be happy. So if you're just starting this work, like, I think that's a really good step. And again, like I kind of said, like wrestling with it. If you have negative thoughts come straight up, you know, we live in a fat phobic society, so that's not surprising, right? So instead of pushing them down and being like, oh God, I'm a bad person, bring them up and question them and ask yourself why you feel that way and where those thoughts are coming from, so you can sort of start to unpick them.
Thank you. Carrie asks, when a client uses the word fat in a derogatory way, you said you don't respond in the same way. Can you model for us what you do say in response?
Yeah, I also use the word fat, but it's just like, I guess, a different tone. Like, and this is a client I'm currently working with, and it's still there a little bit, her negative tone about it and how she's using it to kind of, I feel like she's using it to test me and to sort of wound herself a little bit when she says it, but it's shifting ever so slightly, because I just say it back and we talk about the word fat, right? Like, you know, and I ask her very candid questions. She is in a larger body. So what is it like to be fat? What is your experience? Why do you think that you deserve that treatment? That's kind of a big one, right? Because internalized fat phobia is a thing too. People in larger bodies thinking that they deserve less or deserve poor treatment and that they should change their bodies. So working on that and incorporating the word fat in a neutral way in that whole discussion, just I think it shifts it away from being derogatory, if that makes sense.
Thank you. We'll do one more question. I know it's past the top of the hour and folks have to hop off. So the last question is from Kelly, and it's similar to the resources question, only this is for patients. So Kelly says, do you have any recommendations for social media accounts, podcasts, books, etc., to help patients get some of these messages? So not necessarily the clinical side, the patient side.
So a great podcast, which I'm glad you said podcast because I love this podcast, is called Maintenance Phase. And it does a great job. It focuses on different topics every other week. They've done calorie counting. One of the hosts is Aubrey Gordon, and her books are also really great for patients, clients, anybody wanting to learn more about this subject. So she's a woman who identifies as fat, and she's been doing this work for a long time. So Aubrey Gordon's a great resource, and her podcast, Maintenance Phase, is super entertaining too. Like, this is not dry stuff. You're like, I better check that out. It's really fun.
Awesome. Thank you. Thank you so much, Claire, for presenting today and for such mindful responses to the questions that were asked. And thanks again for our attendees participating and those who sent in questions. They were really thoughtful and elevated. I felt like it was really a great exchange. So thanks again for being with us today. Again, watch for an email in about an hour with the link to take the post test. We hope to see you next time. In the meantime, stay well. Bye, everybody.